So I'm going to start with introductions of our speakers. And we have with us, very fortunate to have Debbi Juster, who is a family-to-family group facilitator. For 15 years, she's a family-to-family instructor. She's on the board of directors for the John Henry Foundation. She's a NAMI Greater LA County member, an advocate, activist, and a proud mom, and the team captain of the NAMI Walk team. We are not alone. And they were the top team last year, and she wants to invite everyone to join her team this year. There's no cost for everyone to register and join. I'm also pleased to announce or introduce Elizabeth Green, who is a partner at the law firm Cantor & Cantor LLP, and they specialize in obtaining health benefits for patients through appeals and litigation. She's been in 22 years of legal practice. Elizabeth has developed a focus on mental health benefits and particularly the protections provided by federal and state mental health parity laws. Elizabeth enjoys the unique challenges of ERISA and health law and being a passionate and effective advocate for her clients. She received her JD at American University, Washington College of Law, and her BA in English and Women's Studies at UCLA. So welcome, both of you. And again, I'm Traute Winters. I'm the executive director of NAMI Greater LA County, and I've been here since last June, and excited to have you all here. I know Debbi also would like to do the introduction for Pam.
I want to thank Traute and John O'Malley for agreeing to form this panel. I hope that all of you on the panel will learn something that's helpful. If our mental health system wasn't broken, we wouldn't all be here. So by the end of the panel, I hope you'll have a better idea of how to learn and educate yourself about what you need with respect to mental health services and addiction services, what you are entitled to, and to how to go about getting it. You'll also learn about the Department of Managed Healthcare DMHC website. We'll get to that later, and how to use it to your advantage. I'm really delighted, though, to start off by introducing someone who can share a personal story of actually succeeding in this David versus Goliath struggle. And that's, I'm honored to introduce Pam Bacon.
Thank you. I'm Pam, and I'm sitting down so no one can see my body shape, but I think I look more like David than Goliath. I just wanted to tell a personal story for myself because I have experience in dealing with a large insurance company and appealing decisions. If an insurance company denies coverage and you do not appeal it, you are guaranteed to get nothing. It's a guarantee. I wasn't willing to accept that. I cannot emphasize enough that once denials are received, appeal them. My personal experience began back in 2014 when my daughter was hospitalized. She was in the hospital for 30 days, and the first 11 days were covered by insurance. Very slowly, first 4 days, then 4 days, then 3, and on it went. Then I got that letter that said further coverage is denied as it's not medically necessary. The hospital told me I would either have to pay out of pocket for the rest of the 30 days or they would have to release her. I appealed the decision to their appeals board and it was denied. After my daughter was released from the hospital, I had her at a board and care because I felt she needed to be somewhere full-time as I was working. I didn't know what to do. This was my first experience dealing with appeals. I reached out to family, to friends, to physicians, to attorneys, everybody I knew. How do I overturn how do I appeal a denial? And I was contacted by an attorney who had heard of my denials of coverage. Long story short, this is 2014, asking me if I would be interested in being a representative in a class action lawsuit. I agreed. Long story short, 6 years later in 2020, a settlement with the insurance company was reached. The agreement was the result of a compromise between the parties, and it wasn't to be considered an admission of liability, but I was very satisfied with the result for me. The second time I appealed a denial of coverage was in 2020, more recently. My daughter had moved to the John Henry Foundation in 2019. I began the process of submitting a claim for some of their fees. It took a lot of time filling out claims. The insurance needed more information. There was more back and forth, more phone calls. Then after quite a while, the claim was denied. I appealed it. It went to their higher up. It was denied again. At that point, I was referred to Debbi Jester, happily so. Debbi believed I had a very good case to appeal the denial. She walked me through the process, having me check out the Department of Managed Healthcare, which she referred to earlier and will discuss later. I began the process of dealing directly with them, looking through their website, finding out how to do it, getting lots of paperwork to them. And then ultimately, I was referred to the Department of Insurance, who regulates the health plan of which I was a member. The prior settlement, remember, was handled through an attorney. This time I was doing it on my own. And after massive amounts of paperwork and being very patient in time, in early 2021, I received a letter from the Department of Insurance that said their independent medical review board had determined that the insurance company's denial should be overturned. I think at that point I almost cried. I began receiving reimbursement from the insurance company soon thereafter. So my message is short and very sweet. You have to be patient. Once a denial is received, appeal it. And that's my 8-year story in 4 minutes.
Thank you so much, Pam.
Thank
That's
you.
a great story, and we're going to take you through today how to do those appeals. Debbie's going to kind of walk you through it and the whole process. So what the agenda is, I'm going to take you through a brief presentation about mental health parity, what the law is, and what insurance companies are required to cover. Then Debbi is going to take you, or first we're going to have Elizabeth, who is going to discuss when to go through the appeal process and when do the top 10 things to look for. And then Debbi is going to take us through the DMHC website and different examples of submissions that have been overturned and how to do an appeal. And then we're going to have a panel discussion afterwards for Elizabeth, Debbi, and Pam to answer any questions that you might have. So I think pretty much everyone is on mute right now. And if you could stay on mute until we have the panel discussion, we would appreciate that. And we have open until 8:30. So hopefully we'll have a lot of time at the end for the panel discussion and question and answers. So I'm going to start with information first about NAMI and then mental health parity, because I know some of you may not be as familiar with NAMI as friends may have told you about this webinar. Can everyone see my screen? Yes, okay, great. So who is NAMI? We're the nation's largest grassroots mental health organization, and we were founded in 1979. And we have affiliates across the US, so in every state, for those of you who are outside of the LA area. Feel free to reach out to your NAMI. What we do is we educate and support. We have advocacy on the federal, state level, as well as locally. We provide support and public awareness, and we serve anyone who's been affected by a mental health condition, family members, caregivers. We work with community partners and targeted populations. And the nice thing is that all of our programs we offer at no cost, like this program. So we have many education programs. We have support groups for both peers and family members and friends. We do presentations and outreach in the community. And NAMI Greater LA County is an affiliate that is comprised of many affiliates within LA County, and we provide leadership in advocacy, education support, and public awareness within Los Angeles County. And we represent about 70% of the county. NAMI National is based out of the DC area, and we're a federated model. So underneath NAMI National is NAMI Greater LA County, and then each state also has a NAMI. So NAMI California, they lead the state advocacy as well as various initiatives in the state. And then we have these affiliates locally that are part of NAMI Greater LA County, and most recently the Long Beach area is also part of our affiliate. So let's get into what is mental health parity. So mental health parity requires that there's equal treatment of mental health conditions and substance use disorders in insurance plans. So if you're treated for something like diabetes and you get unlimited doctor visits, then you must get unlimited doctor visits for a mental health condition such as depression or schizophrenia. So they need to treat any mental health condition just like they would any other health condition. And so mental health parity was passed by Congress in 2008. And again, it's the equal coverage of treatment for mental illness and addiction. And in 2013, the federal government released rules to implement the law. So it's kind of evolved over time, and still we're finding that many insurance companies may not be abiding by it. And that's why, we are going through this appeal process as well. So in California, effective as of January 2021, there was additional things that applied to California healthcare service plans and disability insurers. And I'm not going to go over every one of these bullet points. I can send out this presentation afterwards for you to also look at. But what the California mental health parity, it states, requires coverage of the full range of mental illness and substance abuse disorders identified in the most recent version of the American Psychiatric Association Diagnostic and Statistical Manual, so the DSM. It prohibits, I'm going to just mention a couple of these, limiting benefits or coverage for mental health or substance use disorders to short-term or acute care treatment. It prohibits denying medically necessary services on the basis that they should be covered by a public entitlement program. So these are just some of the things that are in effect here in California as well. So who must follow mental health parities? In California, group health plans for employers with 51 or more employees. Most group health plans for employers with 50 or fewer employees, unless they've been grandfathered in, which means that was before the federal parity law went into effect. Also, the federal employee health benefits programs, Medicaid managed care plans, state health insurance programs, some state and local government health plans, and any health plan purchased through the health insurance marketplace. Most individual and group health plans purchased outside the health insurance marketplace, unless they were also grandfathered in. So that's my summary of mental health parity. And again, just want to invite you all during Mental Health Awareness Month to join us, and feel free to reach out to us in the future if we can be of any support. And again, I will send this out to everyone afterwards, so you can have our information. And with that, I am going to now turn it over to Elizabeth.
Thank you. Thanks for having me tonight. I'm really honored to talk to everyone. I want to share, I'll share my screen first. And see, show you a few slides. So I wanted to talk about 10 things you can look for. You need to know about your health insurance policy. So I feel like knowledge is power, but I'm always saying to clients, and it's really hard to fight for your health insurance benefits if you don't know what your rights are. And everything that you need to know about what your rights are going to be is in your policy or plan. It can be really long, it can be really confusing to read. So I wanted to pull out just things that just highlights and things that particularly would apply for mental health benefits, because that's the majority of what I work on. And something that Pam touched on, you have to appeal. You don't get anything if you can't appeal. That's a great message if you remember nothing else from tonight. A second one would be request a copy of your plan or your policy. You can need a copy of it. They can tell you something over the phone, but they aren't held to it. Later in an appeal or in court, some customer service person can tell you over the phone, you have unlimited benefits, or we pay 90%, whatever it may be, but you can look at your plan or your policy and you'll know what's really, what you're really entitled to. The second thing that I advise you to know is what kind of law applies to my policy. Is it ERISA? This is an acronym that you may have heard, the Employee Retirement Income Security Act. It's employee, not employer. This is saying that we often say in our office, it's to protect the employees, protect you, not the employer. And the point of this is employers provide benefits to employees. It started with pension benefits. It's been expanded to disability, life, health, any benefits you think that you get from your employer. This law applies to you. ERISA requires specific procedures that have to be followed by the insurance company when they deny a claim. For example, they have to provide a full and fair review. If you've ever fought and lost against an insurance company, you know that it doesn't always feel like it's full or fair, that you might have been taken advantage of, but that's what the standard is. They have to tell you when and how you respond to appeals. You can be covered under ERISA and it could be insured, meaning that an insurance company funds it, or the employer could decide to self-fund it, which is what a lot of health insurers or health plans do. A big company like IBM or Wells Fargo, any big employer is likely to self-fund their benefits because it's cheaper for them to just put money aside to pay for benefits than to pay through an insurance company or pay for an insurance policy. So that also leads to who's the claims administrator. If you have an insured plan that you just buy off the exchange, something like that, you're going to know the claims administrator is likely the same as who you bought the policy from. If you buy an Anthem Blue Cross policy off the exchange in California, for example, you're likely to have Anthem managing your claim. But it's important to know who the claims administrator is, because that's going to be your point of contact. That's who you're going to be in touch with for claims and appeals. That goes to the claims administrator. Sometimes higher up appeals will go directly to the plan administrator. You won't know unless you see the plan and you see how that's all laid out. Definitely, if you're asking for your plan documents, if you have an employer provided plan, you want to know, where's my plan? What's this plan that she's talking about? You ask your HR department. They have to give you a copy of their plan. Ask in writing. This is the attorney hat I have on, telling you to ask in writing, because if you don't, they can be penalized. If you later sue in court, it's $110 a day for every day after 30 days they don't provide it. So you send a request in for those plan documents and they have to give it within 30 days, or later you can ask in court. I have cases that, we're asking for $30,000 in penalties because they didn't give the plan. It's a really, it's essentially what you need to be able to move forward. So that's why there's a steep penalty there. Okay, pre-authorization request, something that's really important to know, something that I really feel bad if someone comes to me and says, oh, I got this denial. If they said I didn't get pre-authorization. Well, half the time, there's a penalty for pre-authorization. It's not an outright denial. It's just, maybe there's a penalty of $250 or something like that. Sometimes it's a small financial penalty they ding on you if you don't get pre-authorization. But sometimes that they can use that as a basis to deny your entire claim. It doesn't mean, it's a bit of a misnomer because it doesn't mean that they have to pre-authorize it. They're probably going to say no. I mean, if you're fighting about it, they may say no, but you can document that I did ask. Look, I asked for pre-authorization. I went through your steps. I got that. So that's not something that I'm going to get dinged on later. Out-of-network benefits, also something that's really important to know, because some plans, I know that there's some Blue Shield plans that are sold in California, for example, that limits treatment to in-state, and you can't actually get any treatment out of state. And some people don't know that, and they've bought this policy or they got it from their employer, and they're kind of stuck. If you have an EPO or an HMO, you have a specific provider, a network that you've agreed to use by virtue of agreeing to enroll in this plan. But there's always a but if that network is inadequate, you can ask for a single case agreement or what's called a gap exception. So I use the example, if you need to see a cardiologist and your HMO doesn't have a cardiologist, this is an outrageous example because of course they would, but if they don't have a cardiologist, you're entitled to go out of your network and they have to compensate you for that at an in-network level. It's a little tricky because you need to ask ahead of time, and the provider that you're going to use has to agree to say, okay, for this single person, for this single exception, I'm going to be in network for this person. Often I see this when there's a geographic issue, and there's just not a provider within a certain geographic range. It's usually 50 miles, or it's a specialization issue. It can't be just based on preference. Preference isn't really going to get you anywhere. And you also really need to prove up none of these people work. Sometimes it's, you know, I have clients who say, well, I called everybody that they suggested, but they either weren't taking new clients or they don't see children, or, you know, you name it, that there's no one available within the network. So, okay, proof of loss deadlines is my number 6. This is your deadline to submit claims. Just like you have to submit an appeal on time, you've got to submit those claims on time. I know that network providers will often do it for you, but if you're doing an out-of-network claim submission, you got to get the claim form and you have to get it in on time. It could be 6 months from the initial date of treatment. It could be a year, but you don't know unless you have your plan or your policy. So you need that to look that up. And then your appeals. How many appeals do you have? And what's your deadline to submit those appeals? If you have an ERISA plan, you get a minimum of 180 days to submit your appeal. Now, some insurance companies are longer. Cigna is usually 365 days, which is very generous. You really don't want to wait that long to submit your appeals because I'm sure you want resolution before then. But know when those appeals are due and how many appeals do you get. So if you only get one appeal, you're going to want to make that appeal everything as good as possibly can be. I mean, of course, any appeal, you're going to want to make it great. But if you have 2 appeals, you know that you maybe have a little cushion. If you don't get everything in, maybe you get it in for the second appeal. If it comes to that, hopefully it does not. And this does not include an IMR through the DMHC or Department of Insurance. That's like a bonus appeal that you get later that Debbie's going to go into later. The definition of residential treatment. This is a big one, of course, for mental health because residential treatment is specific to mental health. I feel like I've seen all sorts of definitions that can trip people up. There's things that require a psychiatrist who's on staff who sees the patient on a certain amount of days per week, or it could exclude a wilderness program that I know someone else talked about tonight. It could have licensing requirements, which are also really interesting because, of course, these policies are written not necessarily state specific, and it may say something like you need to be licensed as a residential treatment center. Fine, except in states like California that don't license residential treatment centers as residential treatment centers, their license is congregate living facilities. So what do you do with that? You don't, it's not that you don't get the benefit just because they decided that they're going to use this little term. So you need to know what you're going to be up against, definitely for residential treatment, because it's a big one for mental health. Which goes into exclusions. If you see an exclusion for, say, nutritional counseling or residential treatment, then you're either looking at a really old plan, you're looking at a plan that does not have to comply with the ACA, which there are some that are out there that don't have to, few, but there are some invalid exclusions out there. So beware of those. And what is the definition of medical necessity? Most claims for mental health are denied on the basis that it is not medically necessary. And what does that mean? Who says it's not medically necessary? Well, the plan is going to have a definition. It usually says something about generally accepted standards of medical care. California now says that that is the DSM, that encompasses those specific criteria that are in the new law. But some insurance companies will still use criteria if they're not in California or it's not a California insured plan, they can use something else. It's good to know ahead of time what guidelines, what criteria are going to be applied to my benefits and when you're deciding my benefits, because often we don't know until we get a denial letter and it reads, we applied the such and such guidelines, the Milliman guidelines or the Magellan guidelines to deny your benefits. And you say, what? These aren't in my policy. I don't know anything about these. So good to know what it is that you're all working out the same playing field. And here's a bonus one for you to transition to Debbi. What is your time frame here? What's your statute of limits to file a lawsuit? You've done your appeals. You want to just continue this to either file a lawsuit, contact an attorney, or submit an IMR. There's different paths you can take. You need to know what the deadline is to do these so you can move forward in a timely fashion. A statute of limitations to file a lawsuit, I've seen them be as short as like 6 months, which feels a little unfair because by the time you get it, process it, try to find an attorney, get all that, it's 6 months could easily pass. So that's what I wanted to quickly share with you today. And I hope this is helpful. Feel free to, put questions in the chat or we can get to them later. And I'll pass it. Let me stop sharing. See here, stop share. Let me pass it over to Debbi. Thank you, everybody.
Thank you, Elizabeth.
Thank you, Elizabeth. Real quick, Joy has her hand up. If you have a quick question, otherwise, if we could wait till.
I do have a quick question, and that is, where does this stand? Does this include Medicare? And I'm not talking about Medi-Cal or Medicaid, but Medicare.
No, is the short answer. Medicare is sort of its own beast, sort of like TRICARE is. So ERISA does not cover Medicare, and state insurance laws do not cover Medicare either. It has its own set of rules.
I think the one exception I'm aware is Medicare Advantage, which
Right.
I believe Department of Managed Healthcare has oversight for Medicare Advantage. That's the
the supplement. Yes, that's right. Yeah.
Okay, thank you.
Oh, okay. I guess I'm on.
Yes. So I will share my screen now, Debbi.
Okay, great. So hi, I'm Debbi, and I'm going to address the issues of what do you need, and we'll get to the website a little bit later, Traute. First, what do you need? What are you entitled to? And then how do you go about getting it? And starting with what do you need? It's kind of a shame that we even have to talk about what do you need. But due to stigma, we don't really know necessarily what we need for mental health assistance and resources. If we break a leg or we have a laceration, it's kind of obvious. We go and we get our leg fixed or we get our finger sewn up. But when it comes to mental health issues, we generally don't know necessarily what we need. And that's because with stigma, and NAMI is so wonderful in helping us deal with stigma, people don't talk about it so much. People are much more likely to talk about a visit to the cardiologist or a visit to a gynecologist, but not as likely to talk about their last therapy session or what they're doing with their child who has a severe mental illness. So people don't talk and you don't hear as much about it. That's slowly changing, especially with NAMI's assistance, but it's still not something we automatically know. So to try to figure out what do you need, you kind of need to do your homework. And I suggest a wonderful first step is being in a NAMI support group. I'm not going to take a show of hands, but in my many years in NAMI support groups, we learned so much there about everything related to mental health services. Every story is different, and we learn from others. The collective knowledge of everyone in the group is huge, and we really learn so much from each other. Another place where you can learn about what do you need is from a medical provider. If you have a doctor you can talk to, you can say, I'm dealing with this. Where do you think I should go? And the internet. Nowadays, the internet gives us so much information, but you have to really be careful because not everything you read is true. And you may read that something is really great, but that's one person's opinion. One thing I'd like everyone to be aware of is the concept of evidence-based studies. An evidence-based study is something that uses a valid scientific method to study and research the evidence, and it's reviewed by specialists and peers to look at it. I know when I first came into NAMI and I was desperate, as many of us are, someone in NAMI suggested I should get my son treated with hyperbaric oxygen because of something that came out of Russia. And I felt really cornered because I was desperate to do anything. And of course, she never could come up with a study, but it's important to know that not everything you read is true. You really need to look carefully at it. Later, we're going to look at the DMHC website. And if you do all of the above, you don't necessarily, it doesn't make you an expert, but it helps you ask the right questions to try to figure out what do you need and to know who to ask. And thanks to Elizabeth, now we know a lot about the benefits section of our insurance policies, which is really a tough area. And I'm glad Elizabeth talked about it, so I don't need to. Also, in trying to learn about what you're entitled to, I'm going to also address the issue of medical necessity. I define it as needed, appropriate, reasonable, evidence-based, not usually experimental, community standards, and not requested for convenience. I'm going to just mention the DMHC, which you've heard us refer to, is the Consumer Protection Agency in California that oversees the operations of most managed healthcare plans, employee-funded, individual. It manages more than 120 plans and more than 25 million Americans, and that's why we refer to it a lot. They really are a good big brother to have. So according to the DMHC website, which I reviewed for today, what is included as medical necessity, medically necessary treatments? And I just wanted to bring up examples that many of you may have thought of or comes up in your group. One example is extended release forms of drugs. These are more expensive drugs, but are specially coated so that they don't absorb all at once. They absorb over a longer period of time. You don't have to take them as often. And they have fewer side effects because instead of having a sharp uptick and then a down, having a lot of it released into your blood system where you'd have more side effects, it's released more slowly. These are a lot more expensive and they're now regularly being covered. Certain frequency of therapy is also something that could be medically necessary. If you've got a significant mental illness, you probably need therapy regularly, often weekly, not necessarily twice weekly, but you certainly need individual therapy and not just a group being in a group, which is a lot more efficient for insurance companies to put you, in a group. Now, very often you need both, but certainly individual therapy is something that you're entitled to. It is medically necessary. There are various levels, acuity of care, different kinds of groups, not just a support group, but say a group that you go to several days a week. There are two major categories that you'll read about. One is intensive outpatient programs, IOP, and the other one is partial hospitalization programs. That's PHP. You don't live in those places. You live at home, say, or boarding care, and you go there several days a week for several hours. Those are more intense programs than just being in a group or having individual therapy. Another level of treatment is what Elizabeth mentioned, the residential treatment centers. Here you get 24/7 supervision. You live in these places. There's supervision, every day of the week. John Henry Foundation for individuals on the schizophrenia spectrum is amazing. I'm proud to be on the board. We need more places, more RTCs. We just don't have enough. Another level up is inpatient psych. Someone is hospitalized on a 5150 or a 5250. This is the highest level. This is not necessarily one people go to voluntarily. And on the DMHC website, we see where there are rulings about whether or not someone should be admitted to the psych hospital and continue to reside there. The insurance company may say, okay, you've been there 3 days, time to go home. I know if you've been in a support group, you see that over and over again. And so these are addressed by Department Managed Healthcare. And lastly, there's a category that I saw for the first time, and that is normally the insurance company will cover what is the least level of care. In other words, if someone just needs individual therapy, they're not going to be in a residential treatment center. If someone can be treated in a residential treatment center, they're not going to be in a hospital. But because of COVID, there were situations where someone really needed a lower level of care, but it wasn't available. So the insurance companies were forced to pay for the higher level of care because the lower level of care was not available. So what is not included? Now, these are examples I also got on the DMHC website. Newly released drugs. I call these the Me Too drugs. They're super expensive and they haven't been proven to be better than something we've had around for 5 years, 10 years. If they're not proven superior, the insurance company does not have to pay for it. And brand name drugs, they're not, in rare cases, except for rare cases, brand name is not better than generic, and the insurance company does not have to cover that. Genetic testing for psych meds. That's an upcoming field that may change in the future, but right now, if you want this expensive blood test that checks your DNA to see what drug might be better, it's not proven to be medically necessary. And lastly, what's not included is specific medicine regimens. If you have a loved one who's on certain medicines and they're doing fine, but you hear in the support group that something else is new and great, you can't insist that a regimen be changed because something new is out there. If it's not broken, don't try to fix it. Lastly, there's a class called experimental investigational. I learned a good bit reading about this. Experimental mostly is not covered. However, there are exceptions when nothing else that's evidence-based is covered. And this can include something called TCMS, magnetic stimulation that helps, it's been proven to help unipolar depression, but not bipolar depression. But there are cases that someone wasn't doing well, they had tried everything else, And so they were able to get the TCMS for bipolar. And also an example, someone talked about wilderness therapy. I saw something on both sides where wilderness therapy was covered one time because everything else had been tried and the individual wasn't doing well. So they said, gee, what's the downside? And the DMHC overturned the insurance company and said you have to cover wilderness therapy. But I saw other cases where it wasn't covered. So how do you get what you need? If you kind of think you know what you need, how do you get it if it's not offered? Start a file. And I say keep all documents, all reports, all emails, write notes every time you talk to someone at the insurance company, get their name and title, and ask for email or snail mail confirmation of their statements. If it's not in writing, as Elizabeth has alluded to, if it's not in writing, it's not real. And ask, don't be afraid to ask. Ask your provider, ask the case manager, ask membership service, the ombudsman, get everything in writing. If you're told no, ask why. And then the next step is the appeal. There's two levels of appeal, the internal appeal and the external. The internal appeal goes through the insurance company, the health plan. The health plan is in charge here. They generally have to tell you why. They have to say why you can't have what you want. Did they misinterpret your request? Did they say it's not a benefit? Maybe they got the facts wrong. Maybe they say it's not medically necessary. So you need to ask how to appeal. No, sorry, there's not a slide on this at this point. So you need to ask how to appeal within the insurance company. Within the insurance company, there is a person or a committee that determines official appeals inside the insurance company. But you need to find out who is in this committee and what their qualifications are. A dermatologist is not qualified to review a case that involves severe mental illness. For this appeal within the insurance company, you need to explain in writing why your request is necessary, why it's appropriate, and why it's medically necessary. I suggest you get help in preparing your appeal. It makes a difference to have more than one person who's creating this. And find out what the timeline of the appeal is. As Elizabeth alluded to, if they don't give you their response in a timely manner, it will count against them once you go outside. Their decisions have to be timely and in writing. And if this official appeal inside the health plan is denied, they have to send it to you in writing, and they have to say, where should you go for the external appeal? They need to tell you who to go to. 95% of the time, it's Department of Managed Healthcare. Only 5% of the time does it go to the Department of Insurance. Pam's case was the first and only case I worked with where it went to the Department of Insurance. We're not going to mention what that health plan is. I don't quite understand why, but if you go to DMHC and they're not going to cover it, they'll tell you, like they did Pam, they'll say, okay, go to the Department of Insurance. So then we go to the external appeal. For this, we're going to show you shortly on the website how to do this. You explain your case in writing. You provide all documentation, a one-page mental health summary, letters from experts, and any evidence-based studies you want to include. And I mentioned the one-page mental health summary. If you're in our NAMI support groups, most of you, in the one I'm participated in, day one, you hear about this one-page mental health summary. This is so valuable because instead of writing lots of words, it puts everything in bullet points and it summarizes things. It's like the table of contents. It kind of prepares you for what's going to happen. And I think whether you're dealing with 911, with an emergency room, or with DMHC, having this on the top of the stack really lays out your story and gives people a really helpful preview of what's coming. So when you go to the DMHC, they will send your appeal to an independent third party. This is the IMR. We're going to show you this shortly. It's 1 or 3 physicians with relevant specialty and practice. These are not hired guns who make their living testifying in court. These are doctors who are in practice, and this is their specialty. This internal medical review, IMR, has the final say. If your insurance company is overturned, they have to pay. They can't appeal. The IMR has the final say. There are 2 kinds of appeals. One is expedited and one is standard. If a delay would result in harm or death, then the situation is expedited and you get the response within days. Otherwise, it's weeks. So now I'd like to come to the DMHC website, which Traute is going to help us navigate, because I'm horrible with the computer and because I had both my cataracts removed yesterday. I'm a little visually impaired today, if you see me squinting. So if you go into the computer and you type in DMHC California, this is what you get. And Traute, let's keep, if I'm going too fast or we can't find it, talk with me, because we're doing this as a team.
Yeah, dmhc.ca.gov, G-O-V.
Look at the phone number. I have never had anyone tell me that when they called here, the people weren't incredibly helpful. The people that work for DMHC have been, without exception, really motivated and helpful to help you. They're on your side, actually. So don't be afraid to call this phone number and ask for help. And also, if you need something expedited because they're trying to discharge your loved one prematurely from the hospital, they'll help get things going really quickly. So let's see. So we already talked, actually, Elizabeth already alluded to what kind of insurances are included. I think exclusions are most Medi-Cal, Medicare, military, and a few others that were already mentioned, but you can go on this website and it will show you a lot about all the insurance companies. We can't really get into everything here. There's too much for today. Okay, was there anything else, Traute, on this page? Or we're going to go and show you, let's scroll down. There's a lot of information here. We can't really get into all of it, but on this link, they show you at the how to make an appeal. Oh, let's go back to the top. Sorry. So how to file a complaint on the top left. Now, a complaint isn't necessarily an appeal. A complaint could be they're not answering the phones, they're not getting back to me, my doctor didn't shower, or whatever. Or the complaint could be an appeal, that they're not giving me a service that I want. So if you click on there, it gives you exactly the steps, and you can file an appeal online, or if you're a dinosaur like me, you can do it with snail mail. And they show you how to submit it online, how to submit it mail, and how to submit fax. Okay, they tell you what papers they need, what documents they need. They walk you through the steps, and the people on the phone will help you in doing that as well. So great. So
yeah, so it brings you to this form and tells you all the information. You just fill out this form if you do it online.
Pam, I did mine by mail. Pam, did you do yours by mail? I can't.
Yes.
Okay, yeah. So I did mine by mail. Most people I know did it by mail because it's hard to. Well, I guess it's just easier for some of our people in our generation. Maybe
Yes.
it's generational, but
I agree.
okay.
And then, so the forms are here for you to download and submit it by mail as well. And then they also have where to fax it to. And here's the address of where to mail it to.
And I know you're thinking, well, gee, is it worth going through? Pamela, she gives a rosy picture. Her case worked, Debbi worked. Should I really bother? I'll tell you, 68% of appeals are successful. That means 68% of the time we win. The health plan loses. That's almost 7 out of 10. That's pretty good odds. I know you don't get those odds in Vegas. So it's certainly worthwhile try. 68% of the appeals are successful. So let's look at actual cases, and I put together a kind of bunch of different kind of cases just to show you the range of cases that you can appeal. For that, we're going to go up to the top of this page where it shows data and research. Okay, so we're going to click on there, and then we go to search independent medical review decisions. And then down the page, search IMR decisions. Okay, so we're going to go through a bunch of cases. So we're going to try to go slowly so that you can see we're going to start clicking on advanced, and then we're just going to show you a case of experimental. Okay, click on experimental. We're going to do years 2018 to 2019. And for our purpose, diagnosis category, we're going to say mental disorder.
So you can see here that you can do this for any disease. It doesn't just have to be mental illness, pretty much.
Yes, that's true. Thank you. We're focusing on mental illness today, but this is for any kind of, to DMHC is for any kind of complaint, not just for mental illness. And then look at treatment category. We're going to do any category here, and then click on search. And so if we look at the determination, the third over determination, if you scroll down, you'll see most of these experimental and investigational, most of those are upholds. That means you didn't win. The insurance company was not overturned. There's some overturns at the top, but if we go down, most of the time, you're not going to win if you want something that's experimental, because it's not evidence-based. It's not medically necessary. So there's many more overturns for experimental. And let's, okay. Oh, let me grab my sheet here. Sorry, I lost my. Okay, so the next, so let's see which one. Okay, give me a second. I apologize, folks. My eyes are having a little trouble. Okay.
Do you want me to click on the example?
So here, so yeah, let's go to this one example. You have the number 29164.
Yes, I've clicked on it.
Right, and so it gives a summary, several sentences. Prior to 2019, the summaries were pretty simple. Most people could follow them. It explained what was requested, why it was or wasn't indicated with a few sentences. And in this case, it said genetic testing was not likely to benefit the treatment. So this time it was, the insurance company was upheld so that, you know, the people who wanted it didn't get what they wanted. So that's an example of when the health plan is upheld. So let's go back to the top, and we're going to go to the category of medical necessity. We're going to stay with advanced, and then for type, we're going to go to medical necessity.
Okay, got it.
We're going to look at 2018 to 22, and then for a diagnosis, we're going to put mental disorder, and for subcategory schizophrenia. And let's go for searching, go to search cases. And now look here, most of these are overturned. If we scroll down and look at the third category, which is determination, most are upturned. You guys, you're winning. If you go take it this far, your good chance are that you're going to overturn, the health plan is going to be overturned. And if you look over at the far right category, you see that lots of these are residential treatment center, RTC. They're like John Henry. Now, why, I can't explain why, but there's a lot of these. I don't think a lot of people are aware of what a residential treatment center is. There aren't enough of these, there aren't enough of John Henrys. And part of the reason is that insurance companies don't pay for it. And if you win and they do pay for it, they make your life miserable, requesting unnecessary documentation, making life miserable for any facility, which is a topic for another day. So let's look at a particular case here, 29148.
Yep, got it.
Okay. Here we're going to clicking on the plus sign on the left. It gives you a nice summary. Here they're asking for reimbursement for inpatient for a psych hospital. If you read the first 4 sentences, the summary is that discharge prior to the date the patient was discharged would have been premature. It would have been harmful to the patients. So, this is a great case. It shows that inpatient hospitalization, you can overturn the health plan on this case. Let's go to another case. And if you have specific questions, we can answer them later. Just because I'm having eye challenges and it's easier for me to go through this once and then answer questions. So let's go, Traute, to the next one, which is 2019.
Yeah, I have it open.
31256.
Yes.
Okay, this is a typical case that I hear in our support group. You can look at the summary. The patient was hospitalized many times. The patient was non-compliant with meds or treatment. The patient didn't have insight. The patient was arrested, and the jail psychiatrist determined that he needed 24/7 supervision. That's residential treatment center. Now, if you look here, you see a much more complicated summary. After 2018, the powers that be decided that the summaries were maybe too subjective and they wanted to make it more objective. So they developed a tool to evaluate each case to develop level of acuity. It's called the LOCUS tool. And if you see it refer to LOCUS, which is level of care utilization system. And they have 6 criteria. Just to summarize, there's 6 criteria, and each criteria is judged and given a numerical value. And the sum is determined, and the greater the number, the greater the acuity. It includes risk of self-harm, functional ability, whether if there's a dual diagnosis, if the recovery environment is stressed or disruptive, and whether the patient is able to cooperate and has insight. So from 2019 to now, all cases have a LOCUS determination as part of the summary. So when you read it, you'll understand that's what this LOCUS is. So here, with the LOCUS tool was used and determined that, this person really needed 24/7. And it always ends by saying the reviewer is an expert in the treatment of this medical condition. So this is an example of where, the person needs to be in a residential treatment center. So let's go to another case. Let's see.
20338.
3843. Okay. So this is a case not for admission to a residential treatment center, but continued. Look at this first sentence. Continued residential treatment center. In other words, the patient was already there, and family wanted the patient to stay there, and the insurance company was overturned, you won. Okay, and most of the medical necessity cases, you win. So this is continued stay at residential treatment center. So now let's go to the next one. We've just got a couple more.
2938.
2938. Okay.
Wait.
Yeah, Traute, you're doing an
I'm
amazing.
sorry.
Okay, that's good. You're doing an amazing job of following me here. So that's off to Traute. This isn't easy, but every time the screen moves, my eyes have trouble.
Okay, here I got it.
You got it. Okay, so here is a case where the family wanted reimbursement for inpatient hospitalization. The health plan didn't want to pay for the hospitalization, and the health plan was overturned. This is for a diagnosis of schizophrenia. I hear these cases in our support group almost weekly. So, this is encouragement that we can fight. So let's look at a different kind of case. Going back to the top here, we'll go from advanced to basic. So instead of being on advanced, we're going to click on basic. We're going to look at any determinant, let's see, medical necessity for type, and for the year. Yeah, so we're going to search here for search cases.
Do we want to do bipolar?
Okay, let's see. This one is, let's see. This one is search case. Any determinations of key mental illness. Let's see. Let's just do keys. Let's see, mental illness for this one. And search cases. Shelley, we'll come to your answer, your question later. So this is 33491. Let's see, 23. So 233491. And look at the far right corner. There's the fourth one down is intensive outpatient program. The fifth one down is intensive outpatient program. So this shows, it's not just residential treatment center. It's, people who are living at home, but they need more help. That's what the IOPs are for. So this is 33491. Let's see, 33. Okay.
Yeah, right here.
And here. So look at this case. This is the family wanted reimbursement for weekly therapy. Look at the first two sentences. Debilitating anxiety, depression, crying spells, medicines were tried. The patient needed therapy and it helped her. And the health plan denied it. Well, guess what? They were overturned. This person got weekly therapy, which, I'm horrified that these kind of cases have to be appealed. But, you guys have to fight. You have to fight here, okay? So the next one is for a bipolar individual, going back to advanced.
Okay.
And to 2019 and bipolar. We can just do 2019 to current, make it easier on Traute. And yeah, so we'll search cases here. And here's
I've got it. 193.
Okay, so let's look at the summary here. 1930409. Okay,
Yeah.
great. Okay. Great work. This is hard for Traute. Okay. So an individual with bipolar disease and PTSD, look at the top, trouble coping with occupational stress. The patient didn't want to take meds, was getting therapy twice a week. Okay, not once a week, but twice a week, and got a lot better. Now, this is the only case I've seen where they covered twice weekly therapy. And I just bring this up because, it doesn't hurt to ask for something, especially if you really think it's going to help. Most cases, most of the time, I think they're only gonna give you once a week, but this was an individual who really needed twice weekly therapy. Okay, most people won't have access to that, but gee, this really made a difference for the person, and it worked and it helped us. So you won. This was overturned. The last case, okay, another bipolar, someone with bipolar disease. Last case, I promised, and we'll get to questions, is, and you'll see why it's an out-of-state case. Okay, 55, let's see, 213
6558.
558.
I got it.
Okay, good work. Wow. So this is a bipolar adolescent. Now, for those of you who looked for service for adolescents, there aren't just not a lot of services or not a lot of places for adolescents. It's bad enough if you're an adult. If you're an adolescent, there's just so few. There's someone in our group that just has a loved one going to a place in Miami. I don't know if you're on this call, but to Florida. Well, here the family wanted coverage for an out-of-state RTC, residential treatment center, and PHP, partial hospitalization, at the University of Utah. Guess what? The health plan was overturned. You won. So, you got to go and do what's best for your loved one. And if it means going out of state and thinking outside the box and wilderness therapy, whatever it might be, go for it. And so thanks for being Traute, for doing such an amazing job on this roadmap here. I know for those of you watching, it's very, very hard. And yes, if your child is transgender, it's even more challenging. I totally agree. But for those of you watching, you can get in touch with us, and also the recording is going to be helpful. Navigating this website the first time is really hard, and that's why I really wanted to give you the opportunity to see some cases so that you know what to look for here. And when I work with people like I did with Pam, I walk you through it just so you can see, and you can look at cases and see the wording, see what makes a case, why is it that a case is upheld or overturned. And that gives you an ability to write your statement, why it's necessary, because you know what seems to win and what doesn't win when you do your case, when you do your appeal. So I know this is a huge amount of information that for if you're seeing it for the first time is really really hard. And Traute, you did an amazing job of following on that. But I hope this plants the seed and gives you encouragement to appeal there. And I know Traute, I think you're going to handle the questioning.
Sure. Let me go through the chat and see what questions we have. If you want to put your question in the chat, so then I can maybe try to get them as people put the questions in there. Let's see, or at the bottom of the screen also, under reactions, you can raise your hand. And then we can also call on you that way. The PowerPoints, we can send those afterwards. Let's see. What if you did request pre-authorization, but they said facility is on a do not authorize list?
I don't know what a do not authorize list is, but if it's medically necessary and there aren't other options, you can ask your insurance company, well, what do you have to treat this problem with? What's your options? And if they don't have a better option, then this is medically necessary. Elizabeth, do you have a different answer?
I have a case I'm litigating right now where the family asked for a single case agreement because they'd already tried the local residential place and they weren't going to go back there. Didn't work. And at the place they wanted to try, the insurance company said, similar, like it's a no authorization. That's what they say in their notes. But they claim it's not a denial. And I'm like, but that's the same thing. You're just talking semantics at this point. If you're saying you're not authorizing someone, that's a decision that they're making. The term is adverse benefit determination. Is it a benefit decision that's against you? You're asking for something and they're saying no, that's a denial. So you get to appeal it and find out, well, why? Why are you not authorizing them? Are these valid reasons that you're giving? Are they made up reasons? Or, is this a place that you really need? Is it some place that's really specific to your loved one's needs? All of that would be explored in an appeal.
And what if you were told they won't pre-authorize, but they have pre-authorized similar program in the past?
Appeal.
Yeah.
I'm curious, Pam, that you had an experience with a class action and an experience going through the appeal here.
Yes.
How are they different, or what was it like?
Well, with the class action, you're dealing with the attorney and they're handling everything and you're giving them input, but they're the ones that deal directly with the insurance company. With the Department of Managed Healthcare and what you said earlier, Debbie, they were wonderful. I was nervous. You're stressed when you try to do these kinds of appeals. And the people there genuinely were helpful. They acted like they were 100% on your side. And that's probably a big difference. I talked to them a lot. I felt more comfortable calling them a lot than I would say an attorney's office calling a lot. But I was very happy with the outcome. I was very happy the way they treated me. And so when you ran us through this, their website, Debbie, that was helpful because that's what you did with me when I first met you. And I went through many of the cases, which gave me the confidence to feel like I really could win this.
And Pam, you got 2 years of residential retroactive paid, is that correct? So she got 2 years of prior residential reimbursed. So, okay, and Pam, I think this is your question. If insurance says neurofeedback is not covered on policy, can you file and possibly win an appeal to show that it was medically necessary and evidence-based, or does the policy exclusion trump the appeal?
I need to see that. Where's that question? I'm trying to follow it.
It's in the chat.
Oh, here it is. Okay, if insurance says it is not covered, can you file? Yeah, if you show that it's medically necessary. Yes, that's like wilderness therapy, or if something is medically necessary, if you can show that, I believe that, and nothing else works. In other words, TCMS, transcranial magnetic stimulation. Okay, it's not evidence-based yet for bipolar depression, but if nothing else is working and it has a chance of helping, then they have to cover it. So DMHC may allow you to get this covered.
Mm-hmm.
Now, I don't know about the legal. Actually, Elizabeth, you're the expert on this. If the policy exclusion trumped the appeal, I'm not a lawyer.
The medical policies that insurance companies write, they update those very frequently with their board of physicians, and they can be wrong. They can not be updated sufficiently. There could be something that they're missing. So it's hard to go right up against the policy and try to combat it at its face. But if you do have medical studies to back you up, this is a proven treatment. If you have really good doctor support, I really can't say enough about good doctor support. You can get a doctor or any treatment team that is willing to write you a really great letter that explains why this is really medically necessary and the risk that your loved one will face if they don't get this particular requested treatment. It's essential. I mean, it's just really important because I can say something, or as a patient or a loved one, you can say it, but it kind of doesn't mean anything unless there's an MD behind it, or, LMFT, like somebody who's got some credentials within the mental health field really goes a long way. So that's a long answer to say, if you really, like Debbie's saying, if you have really good medical support, for your particular circumstances, then yeah, challenge their policy.
Okay, Shelley Hoffman, I see your hand raised, and I see your question in the chat. If you try to get a pre-authorization and it is denied, you can appeal to hopefully get denials overturned and then have your loved one get into the residential treatment center.
Do you mean denied by the health plan? Because a denial by the health plan, that's the whole reason to go to DMHC is to overturn a denial by the health plan. Am I understanding you?
Here, you can unmute, Shelley.
Yes, I mean, like in Pam's case, her daughter was already at the facility for 2 years when she submitted and was denied and then she appealed. My son is not at that place, but if I were to request a pre-authorization to go to what I believe is a medically necessary residential treatment facility, first of all, they have to accept him, right? But I would go to insurance, say, I want this pre-authorized, assuming they'll deny it, then I appeal it. And then I'd go to the managed health care. But I could do all this and then get him in, possibly.
I actually saw one case where they were asking for one of 3 RTCs and it was approved.
Okay.
So I think because you don't necessarily know where your loved one is going to, which, facility your loved one will get into, I think you can get them to agree that someone needs a level of care.
Okay.
So I did see at least one case where that happened.
Okay.
My only suggestion on that, Shelley, is your timing, because you're going to have evidence and support that is kind of in a moment in time, right? Like say it's now, like you want to get him in now, but you don't want to appeal to the DMHC in 6 months because then your information is going to be a little dated. You want to make sure you do it in a really timely fashion, like get those letters, get the request in, like have everything sort of lined up, ready to go. Does that make sense? So that they're not looking at something and saying, well, that's great, that was 6 months ago, how's he doing now? Chances are he's probably doing worse because he hasn't had treatment.
Right,
but,
right.
Right. But you need something to say that.
Okay.
Yeah.
Thank you.
I think we answered this question. If someone has Medicare Advantage, are they helped by DMHC?
I think I saw that DMHC does have oversight over Medicare. That's the only Medicare that it has advantage over, that it has oversight over. Is that correct, Elizabeth?
I think so, a supplement plan. It wouldn't be the primary Medicare plan.
Okay.
Yeah.
If someone is in an RTC out of the country, can DMHC help with reimbursement through Kaiser Permanente?
Out of the country. Boy, I can't answer that. I can see lots of challenges in that. But I've never seen a case. I've never seen.
Kaiser has a really specific referral process that you have to go through to get any out of Kaiser provider. But you can do that. You can certainly do it, and you can see if they'll cover someone out of the country. But with Kaiser, it's its own process to cross every T, dot every I, make sure that you get that referral checked off. And some policies where this is where you have to check the policy again. Some policies don't provide for out of country services, which is why sometimes people get a supplemental policy if they're out of the country. But then there are like anthems that have like their worldwide network, like the Blue Network, that might be out of the country. So I don't know what Kaiser has in that regard.
All right, I think that's it for the questions. Does anyone else have a question? Sure, Rhonda.
Hi, I'm sorry. I was trying to type and I'm having I'm trying to navigate this site. I've never used it. It would sound like that the majority of what you all are talking about tonight has to do with private insurance. It is not applicable to the person who is already in, say, the disability arena and has Medi-Cal. It sounds like that's sort of a whole different venue to navigate through, which is where I'm at with our daughter and trying to, and I wondered if anybody, especially the attorney, has any type of history or application of American Disabilities Act on what a mental health patient deserves in services. I mean, don't they fall under that somewhat? Does that,
Well,
that makes sense? In other words, there's an
yeah.
American Disabilities Act. And that gives people with a disability every right to services. And I happen to know in other arenas, they get extensive support, you know, 2 people to a person. And I'm not at all, or say in the case of drug addiction, sometimes you'll have people in a facility where as a strictly mental health person, it's an extreme challenge, or they sit waiting, in my opinion, sort of not fully serviced for an opening to become available. And I'm not talking days or weeks, I'm talking months and months. But it sounds like what you all, and I wasn't sure when I came in, were addressing was people who have private insurance and how you navigate getting one's private insurance to pay for your loved one's services. And my question is, if somebody is specifically Medi-Cal, how do you put a fire into them to, you know, when the wait list is so long for places, and it seems sort of, it's almost like hush hush, and a lot of hidden, they don't really, you know, always, some do, but don't want to really talk to you about. You have to go through many gatekeepers, and you ask for things in writing, and they can't provide it. They won't or cannot provide it, you know, about facilities, the criterias.
You raise
I
a,
fully understand this whole thing in writing.
Rhonda, you raise a really, a real terrible problem in our broken mental health system. I know that when you have Medi-Cal, it's a little harder to get a 5150. If you have insurance and you can show that there's a bed available, they're more likely to take someone to the emergency room. And then if you're in the hospital, say, and you need to go to an IMD, a locked facility after the hospital, it doesn't really, at that point, it won't matter what the insurance is, but to get into the hospital, it's harder. And then, you know, RTCs, well, you know, John Henry, you have to say you're going to, you know, the family has to volunteer that you're going to cover it. And if you get insurance to reimburse you, that's fine, but you have to be, the residential treatment center can't take on the onus of, well, are we going to get paid or not? So it won't, you know, it doesn't work if, you know, and I know if you have SSI, then that can go towards the payment at the RTC, but the RTC can't say, well, you know, we'll accept someone, but we don't know if we're really going to get paid. So that's a problem. We don't have enough services in our country.
Well, no, LA County specifically, they actually have programs where they're housing people because they don't have placement for them. And so I guess my question is, you know, from a civil rights perspective, the American Disabilities Act, I mean, people with disabilities are afforded the opportunity for services. Is that not true for the mental health patient as well?
There aren't
Is there a
enough
crossover
services.
there? Or does anybody know the answer to that?
There aren't enough facilities. There aren't enough services. There aren't enough RTCs. There aren't enough outpatient programs. And that's why our jails are the major mental hospitals in our country. The top 3 mental hospitals are jails in New Jersey, Los Angeles, and Chicago. So, you know, that's, our system is broken. That's why we have to work with NAMI, a little plug to fight, because we don't have enough services.
I saw Shelley's hand was raised. Did you have
Yeah.
a solution for us?
I agree, Rhonda. It's, you know, this is really about getting this forum is about getting, private insurance to fund things that they
Okay.
have not funded and that you have to fight to get them to fund. LA County, Medi-Cal is a whole other bag of worms or can of worms in terms of challenges and lack of, substantive care and resources. That's a whole other bag of, can of worms. So
Right,
yes,
well,
you are right
and-
that it
and I just-
is civil rights. It is a civil rights issue, and they failed us and they continue to fail us. So that's where advocacy comes in.
Well,
Your NAMI and treatment advocacy
Debbie
and writing
made a
your,
point of,
yeah,
Yeah, and we're
Right.
in the process, I appreciate the conversation, but we're out of time now. It's 8:31, so I want to be
Okay.
cognizant of everyone's time and,
Okay.
we're putting together our advocacy platform for the county and we may have additional webinars like this, that talk about
Okay.
resources and options for those on public benefits. But I do want to thank Debbi for, all of her great work that she's doing. And, I know she's been very helpful to many of the people that go to her support group. And I think this has been a really great webinar. So thank you so much, Debbi and Elizabeth as well. Really appreciate all of your insights and support, and Pam for sharing your story. And thank you all for attending. And I will follow up with the slides. And so, and the link to the recording as well.
Okay,
So I hope you all have a
Thank you.
great rest of your evening.
thank you, Traute.
Thank you, Traute.
Thank you, Debbie.
Thank you, Traute. Thanks, Debbie.
Okay,
Pam.
thank you.
Yeah.